Mr. Chairman, I believe we're good to go, sir. Thank you, everyone, for your patience.
Thank you. Sorry for that interruption. So I left off about the difficulty in getting these services. This is unacceptable. One of our basic responsibilities as elected officials is to care for the well-being of our constituents. That means ensuring people have sufficient access to affordable behavioral and mental health care. The first step is enforcing the laws we have already passed. We should all be able to agree that this is a step worth taking to ensure that all Americans have access to the care that they need and we all benefit from. And we must take additional steps to build upon these laws to ensure that they are more fully protect consumers and are as efficient in delivering services as possible. I also know that many employers, unions, health plans, and providers are rising to the challenge to meet the unique needs of workers and families during this time, and we look forward to the benefit of what they are doing after the pandemic. I also look forward to hearing from our expert witnesses about solutions to securing access to equitable mental and behavioral health care for all of our constituents, all Americans. I'd now like to recognize the distinguished ranking member for the purpose of making an opening statement. Congressmember Allen.
Great. Thank you, Chairman. We're having a little anxiety and behavioral problems with technology today. It makes us all a little anxious, doesn't it? But I want to thank everybody for joining us here today for this important discussion about the quality and accessibility of mental health and behavioral health services for American workers. The well-being of America's workers has always been a priority for committee Republicans. That's why Congress is engaged in ongoing efforts to address workers' mental and behavioral health needs, including efforts to improve access to high-quality and innovative treatment and services. Sadly, due to the COVID-19 pandemic and related lockdowns, this past year has been very trying for families across the country. Almost overnight, schools and workplaces closed, upending Americans' lives, and creating barriers to key mental health services. While upsetting, but perhaps not surprising, these events triggered an increase in symptoms of anxiety and depression in the United States. In 2020, 4 in 10 adults reported symptoms of anxiety or depression, up from 1 in 10 in 2019. More Americans are struggling with substance abuse use disorder, leading to rising overhead death rates. In response to growing mental health needs, Congress in a bipartisan manner increased funding to the Substance Abuse and Mental Health Services Administration through the CARES Act and 2021 appropriations, which included additional money for emergency grants for behavioral health services to states and other grantees. The COVID-19 pandemic also accelerated the use of telehealth services. And in response to the increased need, Congress provided additional temporary flexibilities for employers to provide telehealth benefits to more workers. Congress should strongly consider if permanent expansions of telehealth coverage may improve access to quality care, including behavioral health care. As a committee of jurisdiction over employer-sponsored health care, Republicans understand that employers want what is best for their employees, which means having the flexibility to provide quality health care and addressing workers' mental and behavioral health needs. Ensuring workers have access to high-quality treatment services is key to maintaining a healthy and successful workplace. And I add that that is what employers want. Thank you very much, and that concludes, I yield my time.
Thank you, Mr. Allen. Without objection, all other members who wish to insert written statements into the record may do so by submitting them to the committee clerk electronically in Microsoft Word format by 5 p.m. on April 28th, 2021. And now I'd like to welcome and again thank our witnesses. We're just delighted that you would take the time to share your experience and your expertise with the committee on this really important endeavor that we are about to embark on. Dr. Brian Smedley is Chief of Psychology in the Public Interest at the American Psychological Association. He is a psychologist by training and an expert in the field of health equity. Thank you, Doctor, for being here. Dr. Christine Motier, and if I mispronounce your name, please forgive me. It's happened to me many times in my life. And correct us all, correct me, I should say, when you start your comments. Dr. Moutier is Chief Medical Officer at the American Foundation for Suicide Prevention. She is a psychiatrist by training and a leader in the field of suicide prevention. James Gelfand is Senior Vice President for Health Policy at the ERISA Industry Committee. He works on the development of policies that support employer-sponsored health plans. Dr. Mayroom Bento is the founder of PsychAppeal. He is a licensed psychotherapist as well as an attorney who has litigated numerous cases on behalf of consumers and behavioral health providers. Welcome to all of you. Instructions: we appreciate the witnesses for participating again today and look forward to your testimony. Let me remind the witnesses that we have read your statements and they will appear in full in the hearing record. Pursuant to Committee Rule 8D and the committee practice, each of you is asked to limit your oral presentation to a 5-minute summary of your written statement. Before you begin your testimony, please remember to unmute your microphone. During your testimony, staff will be keeping track of time and a timer will sound when time is up. Please be attentive to time, wrap up when your time is over, and remute your microphone. If any of you experience technical difficulties during your testimony or later in the hearing, you should stay connected on the platform, make sure you are muted, and use your phone to immediately call the committee's IT director, whose number was provided to you in advance. We will let all of the witnesses make their presentations before we move to member questions. When answering a question, please remember to unmute your microphone. The witnesses are aware of their responsibility to provide accurate information to the committee, and therefore we will proceed with their testimony. I will first recognize Dr. Smedley. Dr. Smedley, please go ahead.
Thank you, Chairman DeSaulnier. Chairman DeSaulnier, Ranking Member Allen, and members of the subcommittee, thank you for the opportunity to testify today. I'm Dr. Brian Smedley, and I'm the American Psychological Association's Chief of Psychology in the Public Interest. APA's Public Interest Directorate, which I lead, fulfills APA's commitment to apply the science and practice of psychology to the fundamental problems of human welfare and the promotion of equitable and just treatment of all segments of society through education, training, and public policy. The COVID-19 pandemic has contributed to what we have called a mental health tsunami in this country. APA's Stress in America survey series shows that over the past year, COVID-19 consistently exacted a higher emotional toll than other common stressors. We also know that patients' coping mechanisms for the public health and economic impacts of the pandemic are serious and highly individualized, including undesired weight changes, increased use of alcohol and other drugs, or even suicidal behaviors and ideation. Our member clinicians continue to see an increase in patient demand for treatment of anxiety disorders, depressive disorders, and stress or trauma disorders than before COVID-19. Research suggests that we may be grappling with the mental health impact of this pandemic long after the pandemic itself ends. However, we also know that not all Americans are equally affected. The mental health impact of COVID-19 is especially prominent in Black, Indigenous, and other people of color communities, which are more likely to report anxiety about contracting the virus, in addition to other stressors related to the virus, like economic instability. Social and economic inequality, racism, discrimination, and stigma are at the root of mental and behavioral health inequities experienced by BIPOC communities. I'd like to mention two other highly impacted groups. First, children and younger adults are experiencing higher rates of stress, anxiety, and fear than older generations. School closures and social activity suspensions are a factor, but we're particularly concerned about the potential for increased rates of abuse, neglect, or other household trauma occurring in the home. Second, frontline healthcare providers, including psychologists, are also exhibiting more frequent symptoms of post-traumatic stress disorder, depression, anxiety, sleep disorders, and burnout due to the workplace stress occasioned by the pandemic. APA urges action in two key areas in response. First, the 2008 Mental Health Parity Law has in some ways fallen short of its promise. Congress can do more to ensure adequate oversight and enforcement of insurers' compliance with the law and close gaps permitting states to exempt their own employees, including essential frontline workers such as police officers and firefighters, from the law's provisions. The second area is telehealth, which has been a rare silver lining of the pandemic. Congress and CMS have greatly expanded access to telehealth services, including audio-only telehealth under Medicare. We urge the subcommittee to support measures that would ensure that ERISA plans equally cover and reimburse for these services. We also believe Medicare's telemental health coverage flexibilities should extend beyond the pandemic. Specifically, we urge members of the subcommittee to support the Bipartisan Parity Enforcement Act of 2021, H.R. 1364, introduced by Congressman Norcross to strengthen the Department of Labor's ability to enforce the parity law by giving it the authority to levy civil fines. We also urge that we close the loophole in the federal parity law that allows states to opt out of parity requirements for state employees. We also urge that we support increased funding to enable better oversight and stronger enforcement of insurers' compliance with the federal parity law. And we urge you to support measures such as the Bipartisan Telemental Health Improvement Act, H.R. 2264, that would increase private coverage of telebehavioral services, including audio-only services, and establish permanent Medicare coverage of essential mental and behavioral health services by audio-only telehealth. I applaud the committee for examining the long-term behavioral health effects of the pandemic and urge you to support an approach to this crisis that provides equitable access to care and preventive interventions to avert worse patient outcomes further downstream. APA would welcome an opportunity to collaborate with the subcommittee on efforts to address inequitable access to care and the ongoing mental health impact of this pandemic. Thank you for the opportunity to testify today, and I look forward to answering any questions you have.
Thank you, Doctor. That was terrific. We will now go to Dr. Moutier. Doctor?
Sorry about that.
There you go.
Great. I am Dr. Christine Moutier, Chief Medical Officer for the American Foundation for Suicide Prevention, the nation's largest nonprofit dedicated to saving lives and bringing hope to those affected by suicide. My message today about the growing gap between mental health needs and accessible care is critically serious, hopeful, and actionable. Thank you, Chair DeSaulnier, Ranking Member Allen, and members of the subcommittee for your time today. The pandemic has clearly been a time of increased attention to mental health and very real heightened distress in our nation. However, even pre-pandemic, we have seen changes in the landscape around mental health. We've seen a 35% increase in the national suicide rate from 1999 through 2018. 1 in 4 Americans has a diagnosable mental health condition in their lifetime, and yet less than half of those are receiving care. The degree of suffering experienced by millions of Americans and families is enormous, with barriers still impeding mental health being approached on par with physical health. We say there is no health without mental health because research shows the brain and the body are connected. People with mental illness have higher risks of suffering, disability, and die 15 to 20 years younger than their counterparts, mostly due to medical causes. And for people with mental illness, of course, the risk of dying by suicide is also much higher, as much as 30 times higher than the general population. Health system delivery in the US was oddly designed without mental health in mind. The public, including people with lived experience of mental health conditions and suicide loss and suicidal experiences, have been making change at the grassroots level. But until the health system improves and makes mental health a real priority, the gap between the demand for quality, timely, culturally competent treatment and the ability to access those mental health services will only grow larger because attitudes are opening up among the public. Research shows that when primary care and health systems embrace mental health and substance use disorders as integral targets of healthcare delivery, many health outcomes improve. And there are enormous economic benefits for societies that prioritize mental health, a proven return on investment for each dollar spent on mental health promotion and prevention. So in many ways, we cannot afford inaction. To put it succinctly, with all of our advances in science, systems design, and technology, we can and we must reconcile the growing mismatch in our nation's mental health needs with the ability to access services and support. During the COVID-19 pandemic, data show that upwards of 40 to 50% of the population report elevations in experiences of depression, anxiety, trauma, loss, and increased substance use. Suicidal thoughts are also much more prevalent during this time, especially among young people, with 1 in 4 young adults reporting suicidal ideation. As the pandemic has progressed, the proportion of respondents to these surveys with detrimental effects on their mental health continued to rise. And there are reasons to be especially concerned about particular populations: minoritized communities, essential and frontline health workers, caregivers, youth, rural residents, and LGBTQ people. Despite the evident need for broad and equitable access to mental health care, many are having trouble accessing care. These challenges have worsened during the pandemic despite greater access via telehealth services. The subcommittee is asked to consider efforts that would support enhanced mental health parity enforcement to ensure that coverage for mental health care is no less restrictive than medical or surgical care. Recent analyses found evidence of lack of parity in behavioral health services compared with med-surg in terms of higher out-of-network use and lower reimbursement for behavioral services. And these disparities are trending in the wrong direction. There must be much more accountability and oversight of parity to ensure that mental health conditions are not being discriminated against. In closing, I urge the subcommittee to consider legislation and policies to: 1, ensure effective enforcement of mental health parity and broaden access to mental health care generally; 2, support a robust, diverse mental health workforce; and 3, integrate mental health and suicide prevention in health systems, workplaces, and schools as critical touchpoints that can establish a culture that is responsive to mental health needs. The steps we take in the aftermath of the pandemic will set the trajectory for the nation's mental health for years to come. Parity must be enforced and disparities must be addressed to ensure equitable access and care for those in need. I thank the subcommittee for appreciating the gravity of the situation and look forward to hearing your comments and answering your questions. Thank you.
Thank you, Doctor. That was terrific. We will now go to Mr. Gelfand. Please go ahead, Mr. Gelfand.
Thank you, Chair DeSagne, Ranking Member Allen, and members of the subcommittee for this opportunity to testify today. I'm James Gelfand, Senior Vice President for Health Policy at the ERISA Industry Committee, or ERIC, a trade association representing large employer plan sponsors. ERIC member companies are the nation's top employers in every sector of the economy, every region and industry, and in every congressional district. These employers offer comprehensive health benefits. Our member companies pay around 85% of healthcare costs on behalf of beneficiaries, and that would be a gold or a platinum plan if bought on an exchange. And every one of them includes a substantial mental and behavioral health program to protect employees and their families. Employers know all too well the challenges that patients face. Too often, patients lack access to the providers they need. Not enough low-cost in-network doctors available, unacceptable wait times, gaps in information about quality and efficacy. The system is leaving many patients behind. And this is on top of an opioids epidemic. And COVID exacerbated the problem for many. The isolation, the disruption of routine, reduced access to medical care and other interventions all combined to make things harder for patients. Employers are committed to being part of the solution, and we have acted. Employers offer health insurance to help our employees, so when we see unmet needs, we address them. Employers worked hard to stop the opioids crisis. from limiting prescription drug fills to more carefully scrutinizing the facilities and providers in their networks to offering new programs to help employees get counseling and care. Employers have innovated many new programs and strategies to increase access to mental health, from enhancing paid time off to beefing up employee assistance programs, mindfulness campaigns, sleep management programs, crisis hotlines, and much more. Many employers hire vendors specifically to enhance and manage mental and behavioral health benefits. When COVID hit, telehealth really shined, securing care for employees isolated at home. Telehealth vendors compete not just on cost and quality, but on metrics like how quickly they can get a patient access to an appropriate provider. Employers moved quickly to expand telehealth, offering care for free even to patients in high deductible plans, and offering telehealth benefits to part-time workers and others who are not eligible for full benefits. And employers who have worksite health centers often went virtual, offering more mental and behavioral health options to employees. But there's much more we can do. ERIC members have convened a mental health task force and will soon be issuing a report including dozens of policy proposals Congress can implement to improve access and affordability without compromising quality. Here are 3 options to consider today. First, promote cross-state medical practice, especially in ERISA plans. You can instantly improve mental health access for tens of millions of people by allowing some of the excess volume on the coast to serve patients in other parts of the country. Start by passing the TREAT Act to at least solve this during COVID. But long-term, we need a comprehensive solution to connect willing and able providers to patients in need. Second, make the private sector gains in telehealth permanent. Allow employers to offer telehealth benefits to all of our employees. This isn't a replacement for comprehensive health insurance, but it can be a lifeline for mental and behavioral health. Many employers, especially retailers and others with large part-time, hourly, or seasonal workforce, have done amazing work expanding telehealth during COVID. But unless Congress acts soon, these gains will disappear due to antiquated rules. Third, fix the rules in high deductible plans. In the CARES Act last year, Congress temporarily allowed first dollar coverage of telehealth. We should make it permanent and add coverage of worksite health clinics too. If Congress doesn't act, starting on January 1st, tens of millions of patients will have to pay their entire deductible before employers can subsidize these benefits. And one quick caution, these problems won't be solved via penalties and mandates. It might make more money for trial lawyers, but patients will be hurt with higher premiums, lower value networks, and the loss of quality, accessibility, and safety within their plans. Congress has repeatedly told the Department of Labor to do a better job explaining and investigating mental health parity requirements, including more new rules that were passed in December. Let's see how those rules work before piling on. In conclusion, employers are acutely aware of the challenges patients face in accessing quality, affordable mental and behavioral health treatment. We are leading from the front, innovating, and finding ways to help our beneficiaries. But policy changes are needed, especially to ensure that millions can continue to have access to telehealth. We hope to work with Congress to advance meaningful legislation to help our employees and their families. Thank you for this opportunity to testify.
Thank you, Mr. Gelfand. Look forward to working with you for just that purpose. And our last panelist is Dr. Bendo. Please go ahead, Doctor.
Good morning, Chairman DeSaulnier, Ranking Member Allen, and members of the subcommittee. Thank you for the opportunity to testify at today's hearing. I'm Mehran Bendat, founder of California-based Psych Appeal, a law firm exclusively dedicated to mental health insurance advocacy. I am, by education, training, and practice, an attorney and psychotherapist. Since 2011, I have spearheaded cutting-edge litigation against managed care barriers to mental health and substance use treatment. Most of my cases have been brought under ERISA. ERISA establishes uniform, albeit limited protections for approximately 136 million people covered by employer-sponsored health plans, 2/3 of which participate in self-funded plans entirely exempt from state insurance laws and regulation. This renders the Department of Labor's role critical. Since 2014, ERISA has required fully insured small group plans to provide essential mental health benefits. Due to historic discrimination, the Federal Parity Act amended ERISA to prohibit health plans and fiduciaries from imposing disparate lifetime or annual limits, financial requirements, and treatment limitations on mental health and substance use disorder benefits. Unsurprisingly, treatment limitations expressed quantitatively are easier to identify and challenge than undisclosed, as applied, non-quantitative treatment terms, which include medical necessity and network access standards. Consequently, ERISA was recently amended to require health plans to robustly analyze and disclose their non-quantitative treatment limitation comparability analyses. While ERISA provides for essential mental health benefits, it does not define medical necessity, a core term of coverage. And while the Federal Parity Act requires non-quantitative treatment limitations, such as medical necessity, to be applied comparably to mental health and medical benefits, it does not require medical necessity determinations to comport with generally accepted standards of clinical practice, or GASC. Thus, absent ERISA expressly conditioning medical necessity and adherence to GASC, health plans are free to create and operationalize self-serving, overly restrictive medical necessity definitions that undermine access to essential mental health benefits. Even when ERISA plans include medical necessity definitions adherent to GASC, coverage decisions in mental health cases are all too often based on deficient, non-transparent utilization review criteria developed or licensed by risk-bearing health insurance issuers who also act as well-compensated claims administrators for self-funded group plans. This dynamic was fleshed out in the landmark class action, Witt versus United Behavioral Health, in which a federal court found that over a 7-year period, the nation's largest managed behavioral health company developed and applied pervasively flawed utilization review criteria to wrongly deny nearly 70,000 claims for outpatient, intensive outpatient, and residential treatment by ERISA participants. While mental health and substance use disorders are largely chronic and pervasive, UBH's utilization review criteria operationalized an acute care utilization management model that myopically focused on short-term crisis stabilization rather than treatment of underlying conditions. The lack of a uniform definition of medical necessity is not the only impediment to coverage of mental health treatment under ERISA plans. Since ERISA does not establish network adequacy standards, self-funded ERISA plans generally do not provide participants with any notice of timeliness or geographic access standards in plan documents. Absent notice of such standards or remedies for the unavailability of in-network services, ERISA plan participants must often wait protracted periods or travel extensive distances to receive mental health treatment or to obtain inconsistent authorizations for out-of-network care. Given the prevalence of narrow and phantom networks, it is unsurprising that mental health treatment is disproportionately rendered out-of-network or forsaken altogether. In light of the low and disparate reimbursement rates set by health insurance issuers and claims administrators, it is equally unsurprising that mental health providers balk at joining their networks. ERISA's remedial scheme should be updated to account for the modern reality that health plan issuers who serve as claims administrators are the actual fiduciaries who adjudicate mental health benefits on based on self-selected uniform criteria and who sell network access to group health plans. While these fiduciaries enjoy annual profits in the billions, ERISA's deferential standard of judicial review and preclusion of extra contractual damages against them continue to reward and incentivize their brazen self-dealing. To truly guarantee meaningful access to mental health care, I urge Congress to pass the Parity Enforcement Act of 2021 and consider legislation that conditions medical necessity and adherence to GASC, eliminates the deferential standard of judicial review in benefit cases, permits damages against health insurance issuers and claims administrators that discriminate, and protects access to open courts by exempting ERISA claims from binding arbitration. Thank you.
Thank you, Doctor. Under Committee Rule 9A, we will now question witnesses under the 5-minute rule. I will be recognizing subcommittee members in seniority order. Again, to ensure that members' 5-minute rule is adhered to, staff will be keeping track of time and a timer will sign when your time has expired. Please be attentive to the time, wrap up when your time is over, and remute your microphone. As chair, I now recognize myself for 5 minutes. Dr. Ben Dot, apologize for the mispronunciation. Dr. Moutier and my high school French, forgive me for silencing your name. So I wanted to ask you a question about California, my home state's parity law that was recently passed, SB 855. The law included a new definition of the term medical necessity that requires insurance companies to cover behavioral health based on generally accepted standards of care. Could you explore, you did explore this concept of medical necessity in your testimony when you discussed the United Behavioral Health case. I was wondering if you might be willing to briefly give us an assessment of the California law and what lessons can be learned from it.
Sure, my pleasure. I would hold that the California legislation that's now law as of January 1 is and should serve as model legislation around the country. And I would urge Congress to consider adopting the definition of medical necessity in SB 855. Essentially, the law defines medical necessity to mean, among a few other things, that services that are offered for mental substance use disorders must be consistent with generally accepted standards of care. And it requires health insurers who operate in the state of California to make decisions about medical necessity utilizing or based on utilization review criteria that are in fact consistent with generally accepted standards of care. These standards are generally set by nonprofit clinical specialty associations with familiarity over subject matter and peer-reviewed research. In California, the law requires exclusive application of the nonprofit professional society guidelines for determining the level of care, meaning outpatient, intensive outpatient, residential treatment that patients seek. And it limits the ability of insurers to apply self-serving criteria that they develop or license that may not at all be consistent with generally accepted standards of care, that may have boilerplate references and footnotes to underlying standards, but deviate markedly from them.
Thanks. Clearly a challenge as the science evolves to make this as understandable as possible and benefits the consumer, also benefits the employers and the consumer as well in a balanced way. One of the big challenges, of course, the concept of mental health parity and putting it in a reality at the consumer level is dealing with the issue of non-quantitative treatment limits, or NQTL. These are restrictions that plans place on benefits through medical management, have a number of us associated with them, and so it can be tricky to compare between behavioral health and medical and surgical cases. Dr. Bendot, how has the newly enacted law, the Strengthening Behavioral Health Parity Act, helped improve oversight of NQTLs? And can you think of any ways that we should further strengthen them?
So the law is wonderful in that it really shines a light on the most complicated part of parity, which is enforcement and compliance with the non-quantitative treatment limitation rules. As I mentioned in my testimony, non-quantitative treatment limitations can be written, but often they are just applied. In other words, you don't get advance notice of what they are. They are not spelled out for you in the plan documents. So plan sponsor, an employer may write a really nice package or benefits into a plan. But then these plans, especially in the ERISA context, the self-funded plans, are effectively administered day-to-day by claims administrators, not the employers, not the plan sponsors. These claims administrators employ all sorts of internal policies and procedures to effectuate their administration of plans across entire swaths of group plans and market sectors. And the law that has been enacted essentially requires a robust analysis of these as applied as well as written non-quantitative treatment limitations. The issue historically has been that although ERISA requires disclosure of the non-quantitative treatment limitations, employers are generally stumped when asked for these and must obtain them from health insurance issuers.
I'm going to ask you to wrap up, Doctor.
Sure. These aren't often disclosed. So to the extent that the law really takes into account disclosure from health insurance issuers and puts it into the hands of consumers, all the better.
Thank you. Appreciate that. And I want to recognize the ranking member for the purpose of questioning the witnesses. Mr. Allen.
Thank you, Mr. Chairman. Mr. Gilfan, the COVID-19 pandemic has completely disrupted many Americans' way of life. Business closures have caused Americans to relocate to find a job, and students are returning home to live with parents and attending classes online. In relocating, many have unfortunately lost access to mental health care during a time they need it most. Patients may face provider shortages in their new areas. Government lockdowns may prevent them from finding a new provider, and they may be unable to visit their old provider remotely due to barriers created by state licensure laws. How do you propose we overcome these barriers to preserve and expand access to care?
Thank you, Representative Allen. While employers support long-term solutions to increase the supply of mental and behavioral health providers throughout the country, many employees need help right now. They don't have the luxury of waiting for 50 states to sign interstate compacts or for providers to be coaxed into moving from the coast. So to help them right now, employers propose focusing on telehealth. There are willing and able providers out there. Telehealth is interstate commerce, and we should eliminate state barriers by allowing providers who are practicing via telehealth within one uniform framework to see patients in other states. There are half a dozen different ways Congress could do this, but one might be to say that a provider participating in an ERISA plan or a service contracted by an ERISA plan can be subject to one uniform framework.
Well, Congress recently added additional mental health parity requirements as part of the Consolidated Appropriations Act of 2021. Mr. Gilfan, can you update this committee on the implementation status of these new provisions? In your view, is it premature for Congress to consider additional mandates or to suggest monetary penalties for parity violations?
Yes, so in the December omnibus bill, for probably the third time, Congress told Department of Labor to be clear about parity rules and non-quantitative treatment limitations, ordered more audits, and clarified that employers, not vendors, need to have documents ready to explain all the limits in their plans. So this triggered a process by which the employers are now working with vendors to produce a huge amount of documents, explaining any limitations on mental and behavioral health and benefits, analyzing how they compare to the medical side, explaining a lot of very in-depth info. DOL is going to start selecting plans and asking to review this info. So we think it would make sense to see what DOL finds and how employers do on compliance before piling on new requirements or punishments. It's our opinion that employers are doing a good job of compliance and that violations are concentrated outside of the large group self-insured market. It's imperative that we see the results of these new requirements before we invent new ones or create penalties.
Well, as I said in my opening statement, it's obvious we're in the middle of a mental health crisis as COVID-19 pandemic and lockdowns have taken a toll on employers, workers, and their families. How are your member companies helping their employees cope with the stress created by the pandemic and associated lockdowns? Can you elaborate on programs or best practices that Congress should support?
Sure. Employers have been part of the solution, stepping up to improve access for our employees and their families. We've contracted with companies that specialize in this area, created many new programs for employees. Employers are also realized that the pandemic created mental health needs that were beyond just insurance coverage. For instance, people needed time off, and we actually needed management to lead by example and show that it was okay to take their time off. We set up virtual challenges to sort of gamify and get people engaged on these issues. Employers offered online classes and more. But the best thing Congress could probably do would be to give employers more space to experiment and innovate. So right now, the rules related to mental health parity, the ACA, Americans with Disabilities Act, GINA, COBRA, and other laws, they make it super complicated to try anything new. So what if Congress was to say, so long as an employer has a plan that meets requirements under these rules, they could experiment with a new, more limited benefit that could be offered on a supplemental basis, not subject to all of those complicated new rules. That would get new ideas and new money on the table to potentially help employees.
Well, thank you so much. I'm about out of time, but I do understand the importance of price transparency. And if you could address this maybe with another member, we should use every dollar wisely. Employees enrolled in high deductible health plans with health savings accounts are rightly cost conscious and seek to make healthcare choices that work best for their families and their budget. The CARES Act allows employees participating in such plans to benefit from first dollar coverage of telehealth, but only through 2021. And what I'd like you to address is how do you explain further how does first dollar coverage of telehealth services help these patients? And we'll be able to do that with the next question, and I yield back.
Thank you, Mr. Allen. We're now going to go to Chairman Scott for 5 minutes. Chairman Scott.
Thank you, Mr. Chairman. And I'd like to point out that in introducing Dr. Smedley, you left out a substantial portion of his distinguished resume, and that is the fact that a long time ago, he served as a American Psychological Association fellow in a congressional office. Man, he did a great job, and it's great to see him. Great to see him now. So,
Dr. Smedley, I might need an intervention on my behalf with the chairman.
So, Dr. Smedley, we've heard a lot about stretching out the providers we have. What initiatives do we have to increase the number of providers? I understand in terms of psychiatrists, if the VA staffed up appropriately with psychiatrists, there wouldn't be any left for anybody else. And obviously, that is a great problem. What are we doing to increase the number of providers?
Well, thank you, Congressman, and it's good to see you again. You are absolutely right that in terms of the mental health and behavioral health workforce, we are sorely behind. We need to dramatically increase the number of well-trained, culturally competent providers that are available, and we need to increase the diversity of these providers to better reflect the demographics of the U.S. population. At the APA, we're very proud of programs such as the Minority Fellowship Program, which has done a tremendous job in increasing access to behavioral health and mental health careers for diverse populations. These are talented individuals who are often going into underserved communities and providing those services. But we certainly need to increase and expand these kinds of programs. As has been indicated, we are woefully underprepared to address the mental health challenges that are before the country now. So we urge expansion of these kinds of important programs.
Are there scholarship programs or something that can get people on track through college and professional school to get them on track to be providers?
Certainly, there are some resources. Yes, the Minority Fellowship Program helps to provide some of those resources, but it's also true that the National Health Service Corps and other programs have been vitally important in providing access to training, often with service payback agreements, whereby those trainees go into underserved communities for a number of years, provide high quality services in exchange for government assistance with their tuition costs. So again, these programs need to be expanded. They are vitally important, and we certainly call for more psychologists, behavioral health, and mental health professionals to be able to access these important programs, such as the National Health Service Corps.
Thank you. Dr. Bindad, it's true that the Department of Labor has enforcement over ERISA programs in terms of mental health parity. Isn't there a private enforcement right by consumers?
So there is, in fact, a private enforcement right for consumers. The problem, however, is that it is a very limited right. Consumers are not able to generally recover anything more than their benefits. And while $5,000, $10,000 may seem like, and actually be, a lot of money to most Americans, if that's the size of your claim, you're generally not able to pursue it, because there are very few plaintiffs' attorneys around the country who are able to bring claims of that sort. So the end result is that you have lots and lots of people who are out precisely amounts in this kind of range and are unable to vindicate their claims. So essential that the DOL steps in, also essential that Congress consider bringing in, again, the opportunity for extra contractual damages to be obtained from fiduciaries, namely claims administrators, TPAs, that improperly deny claims and disincentivize people from getting the care they need.
What do arbitration clauses do to the right to bring a claim, even if you could bring it?
Well, for one, they make things secret. So DOL doesn't find out about potential allegations and findings. Arbitrations don't always follow the law in the way that courts do. And arbitrations can also potentially limit the types of relief sought. So a real danger.
Thank you, Mr. Chairman.
Thank you, Mr. Scott. I apologize for that, that omission. Next, we go to Mr. Wahlberg. Mr. Wahlberg.
Thank you, Mr. Chairman. And before I begin my questioning, I would like to ask permission for an unanimous consent to put into the record a letter from the Partnership for Employer-Sponsored Coverage, if that would be allowed.
Without objection.
Thank you, Mr. Chairman, and thanks for the hearing today. And thanks to the witnesses for being here. We all know, and as we've heard already in this hearing, that the COVID-19 pandemic has exacerbated barriers to care as people have become fearful or discouraged from traveling to seek the care they need. If there's one bright spot that we've discussed even this morning from the pandemic, it's been the expansion of telehealth services, which really has become a lifeline for ensuring access to healthcare during the pandemic. However, state licensing restrictions can hinder a patient's ability to receive care from health professionals that are not licensed in the patient's state. Occupational licensing reform has been an issue of particular interest of mine, and I recently co-sponsored the TREAT Act, which would provide temporary state licensing reciprocity for licensed practitioners during the COVID-19 public health emergency. And so, Mr. Gelfand, in your written testimony, you note that encouraging interstate provider license reciprocity would improve access to mental health services. Can you please describe the regulatory barriers providers face when they seek to treat patients from across state lines?
Absolutely. Thank you, Mr. Wahlberg. So there is a financial cost for providers to get licensed or certified in different states that cannot be overlooked. We've estimated the cost for a doctor just to practice in the 28 states that participate in the Interstate Medical Licensure Compact at nearly $12,000, payable every 2 years or so. However, that is only one of many complicating factors. Every state has its own set of rules, which could include different continuing education requirements, different renewal rules, different financing systems, et cetera. Some states might require applications to be completed in person. Others might have fingerprinting requirements. The list just goes on. The problem is particularly extreme for patients with rare or complicated diagnoses who need to see a very specialized provider, like those who practice at academic medical centers. But there are many other examples, like a patient who travels a long distance for highly specialized care, but isn't well enough for whom they could travel, or whom traveling would be a major inconvenience. We recently heard a story about a spouse who was left with no other option than to drive his wife, the patient, across the state line into Maryland to receive post-surgery telehealth from her car parked in Maryland, rather than from her home in Delaware, because of the differing rules. So this isn't serving patients, and it's certainly causing a lot of barriers for doctors.
Amazing, amazing. But glad we're finding these things out now. How are employers that operate in multiple states navigating these barriers, and especially as they relate to telehealth?
Right, so an employer-sponsored ERISA plan will offer pretty much identical benefits to all of our beneficiaries all over the country, no matter where they live, where they work, or where they receive medical care, except not for telehealth. Telehealth is governed at the state level, which means that an employee in one state may be able to do all kinds of telehealth visits, whereas in another state, they may be required to do video only. So unless they have broadband internet access, they're banned from telehealth. In some states, the patient can simply pick up their smartphone and find a doctor, while in other states, you can only do telehealth with a provider who is already your doctor. In some states, they don't allow prescriptions over telehealth. In some states, they still have super antiquated originating site rules, as if it was 1992, and to use the internet, we had to go to a cyber cafe. So that's why Eric is calling for a national set of rules for telehealth so that our plan beneficiaries can get one set of rules and we can end this mismatch set that is creating a fundamental unfairness for our employees and their families.
Well, Mr. Gelfand, following that track a bit, as you are well aware, this committee has jurisdiction over the Employee Retirement Income Security Act, ERISA, which was enacted way back in 1974, long before the internet or concept of telehealth. Does Congress need to take a look at ERISA or other laws if we want to encourage expansion of telehealth services and promote states to adopt licensing reciprocity?
It is our belief that ERISA is one avenue through which a national framework could be made such that an ERISA plan could contract with providers and those providers could see their patients in that ERISA plan no matter where they work. There are still going to be details that will have to be worked out to ensure that a patient has somewhere that they can go if there's a problem, that they have an authority that is regulatory in nature. But Congress can absolutely work those problems out. It's not a question of whether, it's a question of how.
Thank you. My time has expired. Appreciate your input. I yield back.
Thank you, Mr. Wahlberg. Nicely done. We are now going to the distinguished gentleman from New York, Mr. Morelli.
Thank you very much, Mr. Chairman, for hosting this hearing on obviously one of the most important questions coming out of the pandemic, and appreciate everything my colleagues said, and appreciate the witnesses. I did want to follow up a little bit with Mr. Wahlberg's questions regarding telehealth. I spent a fair number of years in the state legislature and was a big advocate for telehealth and telemedicine, and I've been I think pleasantly surprised by some of the information that's come out about how people have received treatment and services through telehealth, and it may be just auditory with just telephonically. And I know Dr. Smedley had mentioned it in his opening comments. Just aside from the public policy issue, if we're talking to constituents and taxpayers about telehealth, they may have some hesitancy. They may wonder how this could be successful. You have any thoughts on, first of all, the degree to which people are compliant with going to actual appointments and not missing appointments, which I gather happens in the physical as well as mental health arena with some degree of frequency, how that's worked in the pandemic, and also just the efficacy of treatment, either through telehealth on sessions like this, or that are purely telephonic. Could you just comment on that? Anything that you've gleaned or any information that you've that would help us talk to people about the efficacy of this treatment?
Sorry, Congressman, is that for me?
Yes, sir.
Oh, okay. Yes, thank you. Yes, we certainly know that telehealth services, as has been indicated, can be an equity enhancer in terms of ensuring that people have appropriate access to culturally appropriate mental health services. Reducing geographic, cultural, and linguistic barriers by increasing the pool of available providers to patients is critically important. Certainly, it has great potential to reduce the number of no-shows, and we're certainly looking to compile research on efficacy, but to date, all the indications are that telehealth can provide high-quality services that importantly improve patient outcomes, just as is the case for the traditional in-person service.
Well, I appreciate that. I look forward to working with some of my colleagues to expand opportunities for telehealth services. On a different topic, Dr. Smedley, I wondered, we talked about the disproportionate impact on the pandemic on communities of color, older Americans, and people with disabilities, particularly those who receive long-term care in congregate settings, have also been particularly hard hit by the pandemic. It doesn't get as much attention from my perspective, but can you talk about the impact that it's had on older Americans and people with disabilities, and what you think, if anything, recommendations for us on how we can address this lack of service?
Sure. Congressman, you are correct that there are many populations that have been disproportionately impacted by the COVID pandemic, with the combination of physical distancing, social isolation, economic anxiety, fears of transmitting the virus, And for many in communities of color, we are facing a resurgence of overt expressions of racism, xenophobia, and intolerance, which adds to stress, fear, and anxiety in many communities of color. What can we do? Certainly, number one for me would be to enforce the Mental Health Parity Act, particularly for the Medicaid eligible patient population. Ensuring that we have adequate networks, ensuring adequate reimbursement will be a huge step that can be taken to ensure that these patients have access to needed high quality services. And then, as we've discussed, expanding and ensuring the continuation of audio-only telehealth will be a significant opportunity for patients to receive services that they might not otherwise receive. So these are important steps that Congress can take now, addressing the needs of these vulnerable populations.
And what's your sense of, in terms of the underserved population? You've talked about communities of color. We now just talked about older Americans, people with disabilities. What are the long-term consequences of this? What should we expect in terms of additional healthcare costs, et cetera, going forward as a result of the lack of services during the pandemic?
Sure, as other witnesses have described, we certainly know that there's a strong relationship between mental health symptoms and distress and other physical health symptoms. We absolutely need to address both and ensure that we have a holistic approach to treating the needs of patients, and particularly for those populations that you indicated, which have been historically underserved and marginalized in our healthcare systems.
Terrific. Thank you. Thank you for sharing. You'll bet.
Thank you, Mr. Morelli. We're now going to Mrs. Harshberger.
Thank you, Chairman and Ranking Member Allen. I appreciate the witnesses being here today. I do have experience with this. I've been a pharmacist for 34 years, and I absolutely have seen the increase in mental health, drug therapies, the increase in opioid abuse, especially during COVID-19. I just came back from the border. I hear my counties talking about how methamphetamine use is up by 40%. It's unbelievable. And I think brain health is the last frontier. And I talk to psychologists that say it's absolutely an organ that we treat that we cannot see. And we're one of the few professionals that do that. I live, Mr. Gelfin, I live in an area that's very rural, and we have a deficiency in a limited amount of behavioral health and mental health care providers. And I've talked to counties that absolutely have to wait a year to get one applicant to treat patients in their communities. And I'd like to know what Congress can do as a whole to increase the number of behavioral health providers. I understand telehealth has exploded during COVID, and it's here to stay. And we need to have reciprocity rules. As a pharmacist, I know that every state has different rules. And if I want to reciprocate to another state, that's a large fee. There's different rules, state laws, all that. We know that we need to make that cohesive across state lines, but how do we recruit these individuals, especially into rural areas where they are the hardest hit with the opioid crisis? And, we need those mental health providers there. What can you tell me, and what can Congress do to help with that issue?
Thank you, Representative. In the long term, employers very much support efforts like targeting education funds and loan forgiveness to mental and behavioral health providers. But that's a long-term solution, and it's not going to help your constituents today. So if you want to do something today, the number one thing that Congress should do is just pass the TREAT Act. You pass the TREAT Act, you instantly open up an immense supply of providers to these patients, both via telehealth and in person. But it's only temporary, right? So if we want to sustain the gain, we have to explore permanent solutions to allow cross-state practice. And we have to be honest about this, that it's not at all clear that increasing, pay for providers by, $30, $40 an hour is going to get them to close up shop and move, right? And change where they're practicing. So we need to think about, this committee has jurisdiction over ERISA and could potentially give our plans and their vendors the ability to contract with providers elsewhere and beam them in via telehealth. ERISA is not the only way to do it, but it's a way that this committee could do it and could do it quickly.
Okay. Well, I appreciate that. there's, you know, like I said, we've seen that uptick in opioid abuse. You know, people, they're anxious, and it's those younger people that we see the most, and we've seen an uptick in that. It's because they haven't been on the job, they haven't been able to get out and socialize. That's a huge problem, and I think we would benefit if we did get things opened up, and you know, as more people get vaccinated, hopefully that will happen. But addressing this rural shortage of healthcare providers is key, especially in my district. And I'm here to help in any way I can. And I appreciate all the witnesses today. I know this is a problem. This is something that, like I said, it's the last frontier, and we need to address these situations. And I appreciate you being here, and I yield back.
Thank you. We are now going to recognize Mr. Newgrass from the great state of New Jersey.
Thank you, Chairman, and it's good to see you there. Really appreciate your insight and quite a legacy coming from George Miller and what he's done for this great committee. Dr. Smedley, thank you for your opening comments, particularly in dealing with the parity issue. By giving this additional support, tell me how the Department of Labor can use this to change the way that some of the bad actors are playing now. If you can give us some context on why this is relative and important.
Sure, thank you, Congressman. So as we discussed earlier, what's lacking with the current mental health parity law is teeth, enforcement. And so for the Department of Labor, clearly capacity has been part of the problem. There are an enormous number of insurance plans to regulate, a few investigators. An analogy would be that if we had only one state trooper patrolling I-95 between Washington, D.C. and Richmond, that would not suffice to adequately police that highway. So we need better enforcement, more teeth. We need to ensure adequacy of networks. We need to ensure adequacy of reimbursement. And so your legislation would give the Department of Labor that capacity to ensure that that insurers are complying with the law.
No, certainly appreciate that. I thought you were going to comment about my driving techniques, but the idea we believe, even without police, that they'll do the right thing is simply not happening across the board, and we appreciate it. Dr. Bendat, tell me the ways that insurance companies, as you see them, try to circumvent the Parity Act. What are common areas that you've been involved in or that you've seen that you can share with us?
Sure. So as I mentioned earlier, the easiest way to circumvent parity is to adopt non-quantitative treatment limitations that are not disclosed or that are discrepant, in other words, incomparably applied to mental health and substance use benefits. The most prominent NQTL of them all is medical necessity. Medical necessity is generally, again, something that has to be set by law or plan, and it can be interpreted in different ways if it isn't properly structured. So I would say medical necessity and utilization review criteria that interpret medical necessity. Those are tremendous ways in which insurers can deny coverage without triggering any oversight or alerting the public that there is something really foul going on.
But when you look at the capacity for the Department of Labor in its present configuration to go after this, and there was a letter circulating today by my colleague Joe Courtney about increasing the funding to the Department of Labor. Right now, it seems that the balance is extremely far off. Our capacity to look at this and those to come into compliance willingly. Are there some more subtle ways? The two that you mentioned obviously are out there and easier to see. What are some more of the subtle ways that some of this is going on?
Well, apart from medical necessity and network adequacy, which are huge in their own right and probably the biggest impediments to access to care that health insurance issuers control, you also, and reimbursement figures into the equation. In other words, how are reimbursement rates set? That is not a transparent thing. How are in-network reimbursement rates set? That's particularly not transparent. So when we get more answers to those questions, we'll have a lot more insight as to kind of the methodologies that are being applied and the incomparability. I would also say that apart from these, you've got potential deductibles and plan-specific things that can drive people not to receive benefits. But
very much appreciated, and it's the context of which we live in, and the pandemic. You never want to suggest that there's a silver lining, but the idea that mental health is so important, and so many people who have not really been challenged by it are now seeing it across the board, and we have to get that to them. That's why this legislation is so important. Mr. Chairman, I yield back and thank you for the time.
Thank you, Mr. Norcross. And having ridden with you, I want to confirm your observations about your driving skills. We will now go to Congresswoman Miller.
Sorry.
No worries.
Yeah, Mr. Gelfand, thank you again for your thought-provoking testimony. It's wonderful to hear about the great work that companies across the country are doing to support the health and well-being of our employees. And I have witnessed what we are discussing as I travel the district, and people are struggling to fill their, get workers. But anyway, back to the opiate epidemic, I would like to know, you shared testimony that some actions that employers have taken to combat this terrible epidemic. You've already explained some, but could you expand on any other unique approaches that your member organizations have taken?
Thank you, Representative. Unfortunately, COVID did cause a lot of disruption, including for many employers' opioids mitigation efforts. The economic squeeze separated a lot of employees from these programs, made it impossible to do a lot of things that we were doing in person and activities that we had rolled out. Plus the mental health toll taken on workers because of COVID and because of isolation and lockdowns has led some back to dependency. So this is very real for us. The good news, though, is that many of these programs that we implemented before COVID, we were able to sustain because they were cultural changes within our health benefits. For instance, we're not going back to unlimited fills for opioids. A patient should be dispensed the amount that they need for immediate relief, and this should be monitored and reevaluated. And when possible, a patient should be steered to other options. These are just lessons learned, and we're never going to let those go. And many of the programs that we developed, like educational sessions, group counseling, this can and has gone virtual, and maybe that'll change back when we can meet in person again. But for now, it seems sustainable to use these online platforms.
I do have another comment. Do I have time?
Yes, you do.
Okay. I don't know if this would be the appropriate place, but actually my son-in-law is an orthopedic surgeon, and of course he prescribes these, but he brought up how Americans want to be pain-free and they demand pain relief. And, but then when physicians don't give them what they want, then they turn a bad report in on the physician. And so they're kind of caught in between on that.
Any of you care to comment?
Mr. Chairman, I would, if you don't mind. This speaks to the importance of non-pharmacologic behavioral treatments. There are many behavioral treatments that are highly effective in reducing pain and increasing patient comfort. And of course, they're much healthier coping responses. So doing what we can to ensure the promotion of non-pharmacologic behavioral treatments can be an important and effective alternative.
Well, getting the doctors to use those and then get that out to the patients.
Absolutely. Anyone else?
Thank you.
Thank you, Representative. Is that it? Appreciate it. We will now go to Representative Wild.
Thank you, Mr. Chair. My question is for Dr. Moutier, but I'm happy to have any of the panelists respond. As many of you know, I am proud to be a leading advocate in Congress for excuse me, suicide prevention. I am extremely concerned about the rise in suicide among young people and children and the deterioration of their mental health. And although many have claimed and argued that school closures have adversely affected children's mental health, and I'm sure that is true, we know that this problem existed long before COVID-19. The number of children ages 6 to 12 who visited children's hospitals for suicidal thoughts or self-harm has more than doubled since 2016, according to data released earlier this month from children's hospitals across the country. They documented 5,485 emergency room or inpatient visits for suicidal thoughts and self-harm among 6 to 12-year-olds at these hospitals in 2019, which is notably pre-pandemic, which is up from 2,555 in 2016. And visits for teenagers with suicidal thoughts or self-harm at these hospitals also rose from 2016 to 2019 by a staggering 44%. According to the most recent data we have from the CDC, suicide is now the second leading cause of death among young people ages 15 to 24. How can making sure that our kids get the mental health care they need, including mental health care covered by their health insurance, the same way they cover physical health issues, prevent these suicides and address these suicidal thoughts? And how do we ensure, and I know this has been touched on already, but it's such an important issue, how do we ensure that robust mental health care receives parity in insurance coverage? And with that, Dr. Moutier, I'm going to turn it over to you. And if anybody else would like to weigh in on this very important topic, I'd be happy to hear them. Thank you.
Thank you, Congresswoman Wild. Yes, the suicide crisis in our nation has been on the rise, and that actually is true for all age groups, but certainly for youth. The rise in not only suicidal ideation attempts, but rates has been tremendous pre-COVID. What we know so far during COVID is that during 2020, the number of suicides compared to 2019 actually went down by 5.6% across the nation. We don't know the demographic breakdown of that yet, by age or by race, ethnicity. And we know that the pandemic is affecting all people, but affecting different groups differently. And so I am very concerned about what we will ultimately see in terms of not only the demographic breakdown for suicide rates during 2020, but also now what is coming here now in 2021, because the effects of trauma can be delayed. The big picture is that we have had a broken system when it comes to accessing mental health care. There's been stigma, internal and external cultural barriers, but now that that is going down, I believe that is one of the reasons we see help seeking so much more on the rise, but the access to care has not been there to meet it. And so parity is essential when it comes to suicide prevention. It is one of the most concrete and powerful things we could do to potentially prevent suicide and drive suicide rates back down. And particularly now that mental health needs are being expressed by everyone, as has been pointed out, that's a good thing. People can talk about their internal experiences now, but it's not a good thing if we don't have care that is ready to meet that. And that is certainly incumbent upon the legislative tool that we have to enforce parity, but it also means that parents in schools, in workplaces, that we have to build cultural competency and capacity around being able to dialogue about these things and get people the help that they need.
Thank you. And I'm going to just take the last 30 seconds and ask you, Dr. Moutier, can you comment on the new 988 line for suicide prevention that will be available, I believe, within the next year? Will that help adolescents and children?
Yes, it absolutely will. That will come into effect. It's planned for July 2022. It's an extension of the suicide prevention lifeline. What will happen is that volume will go up tremendously more. Right now we have capacity and limitations due to funding, as well as having culturally appropriate providers available. But yes, that is an enormous opportunity for us as a nation to build a new system that is ready to meet the demand. So the 988 legislation is a critically important piece, but we have to pay attention to how we resource it and staff it.
How we fulfill that need. Thank you so much, Dr. Moody. I look forward to continuing to work with you on this very important topic.
Thank you.
I yield back, Mr. Chair.
Thank you, and thank you for your advocacy on this issue in particular. We next go and recognize Representative Fitzgerald.
Sorry about that.
There you go.
Sorry about that.
No worries.
Yeah, Mr. Gelfand and maybe some of the other witnesses would like to comment as well. Been a challenge over the last year, continually trying to stay in contact with some of the healthcare systems within my congressional seat, and even before that, in my state Senate seat that I had represented for a number of years. But the one hospital is Children's Hospital in Milwaukee, and there was this kind of constant drumbeat about trying to find qualified providers for kids who were experiencing behavioral healthcare issues and obviously issues related not just to the pandemic, but family situation, school situation. And I'm just curious if some of the things that ERIC or its members have done or are currently doing on the provider shortage front, because it seems to be something that you hear about quite a bit.
Thank you, Representative. And Children's Wisconsin is well-known to be an outstanding hospital. So if even they are having trouble attracting these professionals, there should be little doubt that this is a market-wide problem. This is a problem that exists all over the United States. Employers know that sometimes throwing more money at the problem just isn't enough. And in this case, you may be able to double the amount that you're paying per hour, and you still may not get those child psychologists to leave New York and LA. So we think that you have three options here. Option one is focus on increasing the number of these providers that exist. And we should do this, but it takes a lot of time. So that alone won't suffice. Number two is we can do more with the providers that we do have. With more resources, tools, education, collaborative care, and co-location efforts, we can enhance access to care by equipping more professionals to practice in this space. So for instance, funding perinatal psychiatry access programs. But third, and perhaps most immediate, to help patients right now, is we've got to be able to bring those providers from out of state to Wisconsin and into your district. And to do that, we just need more access to telehealth, and we need to be able to facilitate cross-state practice, period.
Thank you, Mr. Chair. Thank you. I yield back.
Thank you, Mr. Fitzgerald. We will now go to Ms. McMahon. Lucy, the floor is yours.
Thank you, Chairman DeSaulnier, and for convening. Thank you so much for convening this group of experts today to discuss the issues
So if you only want to ask one question, tell me.
of access to mental health services.
Questions and I'm not.
Almost a year ago, we began social distancing in order to stop the spread of this deadly pandemic, but social distancing has really taken a toll on our mental health and feelings of isolation and disconnection that has affected just absolutely everyone. And it's been inspiring to see so many people across America kind of come together to actually help and support and service one another. And the mental health and recovery community has really been a shining example, I believe, of how people can really come together to overcome this terrible disease. However, these communities have not always been able to access the care that they need. And we've talked about that today. And COVID-19 has just truly laid bare many of the inequities of our healthcare system. And, I have seen a host of disparities develop and worsen with the onset of this pandemic, even within my own constituency. So as the increased isolation of the pandemic has taken its toll on people with mental health issues, I've observed how barriers to coverage and access to care have just contributed to increased rates of severe mental illness and even suicide. Dr. Bendat, in your testimony, you talked about the issue of the adequacy of provider networks and the importance of making sure that you have enough doctors in your plan and in your plan network to make sure that parity is meaningful. Can you tell us what are some of the issues that lead to relatively narrow behavioral health networks?
Well, so you've got narrow networks that are narrow by design. In other words, there are insurance plans out there that intentionally sell access to networks that are meant to be narrow. Nonetheless, these types of plans are supposed to cover all of the benefits that they promise to offer. So the problem, of course, is that when it comes to mental health care, oftentimes they don't. We also have networks that on the surface appear to be robust. They're not limited. Plans sell them as PPOs, as essentially large group products that they offer the promise of wide coverage. But when patients try to access in-network care for mental health and substance use disorders, they can't. Largely, the issues that they confront have to do with not being able to get timely care. So if there's an urgent situation, patients are not able to access the type of provider within a reasonable period of time, or they can't find someone that is available and accepting patients within a particular distance. The problem is that insurers typically, or thus far at least, have failed to update their provider directories. And so patients are just told, go take a look at our directory, find yourself a provider. That is not a very helpful stance to take when someone is in crisis or in distress. And especially when patients have to call multiple providers and be told, no, we're full, or no, we no longer are with this insurer. That's just terrible. So I would say that putting the onus in the hands of the patient who's already struggling with distress, having that patient look for providers instead of telling them, here's who's available, here's where they are, here's their availability window. That really creates a major barrier to care.
So then let me ask you, how do some states like California, for example, address the issue of network adequacy for insurance? And if you can give us a very brief explanation as to why laws do not apply in self-insured ERISA plans.
Sure. So there's ERISA preemption for self-funded plans, which means that they are just not subject to state laws, period. That is something that only Congress can address. So your committee has absolute jurisdiction over this issue. The way that California deals with fully insured plans is by telling them, hey, you've got to arrange, for example, coverage within 15 miles or 30 minutes to a patient's home. You've got to do it within a certain period of time. If you don't, you must let the patient go out of network and subject the patient to no more than in-network cost sharing. So in other words, if there's a balance, you're on the hook for it, you the insurer, not the patient. That's going to create an incentive for insurers to broaden their networks and to raise reimbursement rates to attract providers.
Thank you, Mr. Bendat. Mr. Chairman, I yield back the balance of my time.
Thank you, Representative. Now we're going to go to the ranking member, Representative Fox.
Thank you, Mr. Chairman. I want to make a quick comment before I ask my questions. It's so frustrating that when we focus these hearings on bashing employers, bashing providers, or bashing healthcare networks. Mr. Gelfand has given us some great alternatives that don't require money. And I think it would have been wonderful if we could have heard more about how the private sector is handling these things and looking for ways. Employers want to help their employees, not harm them. Mr. Gelfand, thank you for being with us today. On June 23rd, 2020, the Department of Labor issued temporary guidance allowing employers to offer standalone telehealth coverage to certain employees ineligible for any other group health plan. Had this guidance increased access to mental health services for employees? Should Congress consider expanding this flexibility to all employees and making it permanent?
Thank you, Dr. Fox. The guidance temporarily allowing standalone telehealth has been a huge success. Millions of part-time workers and others have gained coverage that they didn't have before, largely at the employer's expense, and employers celebrate this. But as you know, though, when the emergency ends, so too does the guidance, and so those benefits will disappear. And keep in mind that the temporary nature of the guidance caused some employers to hold back. So we think that if we were to permanently allow standalone telehealth benefits, a lot more employers would roll it out since they could do it for the long term. And we ought to help even more patients. And we do that by broadening the eligibility to include unenrolled workers, for instance, young adults that are on their parents' plan.
Thank you. Mr. Gelfand, the Mental Health Parity and Addiction Equity Act requires employers who offer mental health and behavioral health benefits do not place more stringent limitations such as visit limits or pre-authorization requirements on those benefits than they do on medical or surgical benefits. Your testimony explains the Department of Labor's parity regulations are especially subjective and difficult to interpret. What steps can Congress or the administration take to ensure that plans are able to comply with mental health parity requirements?
So Congress has more than once directed DOL to better explain the most complicated part of parity, which is the non-quantitative treatment limitations. But for some reason, DOL has given many examples of what is not allowed, but continually failed to give clear guidelines on what is allowed. There is now an extremely complicated self-compliance tool that just seemed to further confuse folks. Considering that these NQTLs did not exist in the legislation that Congress passed, and were invented by President Obama's Department of Labor, the least that the department could do is to give a more complete and comprehensive explanation, not just on how to violate the rules, but on how to affirmatively comply with them. Perhaps the most important thing that Congress can do is to continually support DOL's compliance-driven rather than penalty-driven approach. Right now, when there's a problem, DOL helps the employer to get it right and re-adjudicate claims to make patients whole. This doesn't make much money for trial lawyers, but it ensures that our workers actually get the care that they need.
Thank you. Mr. Gelfand, 151 million Americans are covered under employer-sponsored coverage, which is more individuals than are covered by Medicare, Medicare, or the exchanges. Knowing that employer-sponsored plans are the largest single source of coverage, can you discuss how health benefits, including those related to mental and behavioral health, are mutually beneficial for workers and employers? What actions have employers taken to manage the increasing cost of coverage?
Thank you, Dr. Fox. Employers are committed to offering quality, affordable mental and behavioral health benefits. Remember that parity is not a mandate. Employers are choosing to offer this benefit and thus choosing to become subject to these very complicated rules. But they do it because it's the right thing to do, and it's integral to keeping our employees healthy and productive and providing peace of mind. Now, as with any employee benefit, there are always trade-offs. Some limitations are needed to keep coverage affordable, because if costs go up, healthy employees start opting out, which makes costs go up even more. Now, employers work hard to develop strategies focused on improving health and safety, which can also help to control costs. But in the end, if we're not able to employ sophisticated medical management and offer reasonable reimbursement to providers or make decisions to exclude certain low-value facilities or treatments, this will just make it impossible to offer affordable coverage to our workers.
Yep. Has the COVID-19 pandemic changed the way employers deliver mental health care? And what innovations would you highlight that they have put into place?
So it's safe to say that the past 13 months have seen more innovation and experimentation in employer coverage than ever before. Here are the three big takeaways. First, telehealth is crucial. We can overcome a lot of provider shortages. We can overcome access and wait time problems. And already some are advocating that we need to tear it down by having the government mandate reimbursement rates in telehealth. Second, a lot of people are getting their mental and behavioral health needs met in the primary care setting. We've got to support this. From enhancing worksite health clinics to providing education and resources, this should be an easy one. And third, a lot of our employees are getting support that's not traditionally thought of as medical care, right? Whether that's attending AA meetings or caregiving by family members, or they're engaged in meditation, mindfulness type programs. Employers are going to pivot even more to support these activities, but there are some areas in which law and policy really needs to catch up to help us do that.
Mr. Chairman, I thank you very much. I want to make one quick more comment. My husband was having a problem with terrible indigestion about 3 months ago, and he was able to do a telehealth meeting. He had an appointment with the doctor. The doctor got sick and was afraid to see him in person. And so he had my husband do it through telehealth, and he was able to diagnose, maybe not completely, but help him a lot. So I really am an advocate for the telehealth opportunities that are out there. So thank you, Mr. Chairman, for your dispensation here.
I'm always happy to dispense you, Ranking Member, and as a friend, I just want a brief comment that I was just saying to my staff how happy I was at the tone of this conversation, and that very hopeful that we can work together. So
thank you.
With all due respect, I didn't hear the bashing, although I have heard it in the past. And I do appreciate Mr. Gelfin's comments and look forward to continuing conversation about how we get these needed services, which I hear a consensus about from everyone, as efficiently as possible. And on that, I agree with you.
Thank you.
It's best if employers do it. We just want to make sure that they do. With that, we go to the distinguished gentleman from Michigan, Mr. Lamont.
Thank you so much, Chairman DeSaulnier, for this really important hearing, and thanks to all the witnesses. Dr. Smedley, let me start with you. In your testimony, you discussed the structure of mental health parity enforcement, and you point out there are a lot of problems. Federal oversight of ERISA plans is weakened by several factors. The requirements for insurance laws vary state by state. And for state and local government employees, plans can simply opt out of the system altogether. What long-term consequences could patients experiencing COVID-19 related trauma face if they have limited mental health coverage due to weak enforcement?
Well, thank you, Congressman. As I indicated in my testimony, we are witnessing a mental health tsunami. It is upon us. So it is critically important that we do all we can to ensure access to appropriate behavioral and mental health services. As some of the other witnesses have indicated, the absence of culturally appropriate high quality services can make these conditions worse, leading to far more debilitating illness and worse case, suicidal ideology, et cetera. And has been indicated, these mental health issues are not limited to psychological distress and anxiety. They also manifest as physical health problems as well. So we need to do all we can right now to get out ahead of these challenges, starting with things like putting teeth into the parity law.
Well, so let's focus in particular on the sort of the meat of this question of better enforcement. And given our committee's jurisdiction, which is ERISA, what are your top recommendations to improve enforcement for ERISA plans? Lay that out for us.
Sure, there are a number of steps we can take, and I actually would like to respond to your question more fully with a written statement, but certainly, yes, the legislation offered by Representative Norcross is an important start toward ensuring that we have adequate capacity for enforcement and that plans are aware of the consequences of not ensuring appropriate access to mental and behavioral health services.
Okay, let me ask you about a different thing, which is peer support for people with mental health issues. I'd like to ask you to speak about the importance to that and, whether there are challenges to ensuring that people are able to access the peer supports that may be critical to their ability to build resilience during these difficult times.
That's a great question, Congressman. Thank you for that. Certainly, there are a number of risk factors that people are facing in terms of building and enhancing social support. So certainly the need to be physically distant during this time is one of those, but we have encouraged people while we are physically distancing to be socially to not socially isolate, because it's important that we build those connections. Doing things like training people in psychological first aid and skills for psychological recovery, offer ways of helping to train lay individuals, non-professionals, to provide healthy coping skills and mechanisms to others. And certainly there have been other very impressive developments like mutual aid societies that again provide social support without the risks associated with physically coming together. So it is critically important that we address peer support, these informal sources of support, and often based in communities. Drawing on sources of community-based resiliency are critically important, and we should do all we can to help enhance and support those efforts.
Thank you very much. Mr. Chairman, let me end with a couple of comments. One is a reflection on this whole thing, the immense complexity of achieving parity for mental health services. I just want to emphasize that those of us who support Medicare for all are not just talking about giving the current Medicare program with all its limitations to everybody, but having a full system of healthcare, including dental, vision, and mental health, to all Americans. And secondly, I want to emphasize how strongly I feel that we have a new opportunity to permanently expand telehealth services. I've been on the hearing the whole time, and I think I'm going to try to partner with my colleague from Michigan, Mr. Wahlberg, on this, because his questioning was really great on it. And it'd be wonderful for Mr. Wahlberg and I to be able to collaborate. With that, I yield back, Mr. Chairman, with more thanks for your leadership on this.
Thank you. And I do note the disproportionate number of members from the state of Michigan on this subcommittee. I'm glad to have you all here. Speaking of which, we have a great state. We will now go to the distinguished gentleman from Connecticut, Mr. Courtney.
Thank you, Mr. Chairman. I have not, unfortunately, been able to attend the full hearing as much as Andy did, but I actually just wanted to follow up on his last question with the other witnesses, where again, I thought Dr. Smedley got right into really the crux of the issue, which is what does non-compliance mean to the patient? And Dr. Moutier and Dr. Bendat, if you wanted to sort of comment on what we're really talking about here is the impact on people.
Absolutely. Thank you, Representative Courtney. What it means is that in the moment when an individual or a family is realizing that their loved one may be struggling with a mental health condition, may be suicidal, and so the need becomes dire, that they go to figure out how to access a mental health professional. And there are more external barriers in the way of that than probably any other type of health situation. So, I think it does boil down to the way it's playing out in day-to-day real people's lives and families is presenting enormous and honestly unnecessary barriers that should not be there. It is an absolute form of discrimination right now, the way that mental health conditions are not being addressed in actuality, even though there's a lot now of kind of open-mindedness. I don't want to say lip service, but until we fix this issue, we can say that mental health is valid, critically important, that suicide is a complex but a health issue at the end of the day. But we will only get so far, because in every instance of every suicide prevention effort that is shown to be effective, it drives people who have those needs to a health professional. And so this really is the crux of the matter. And I appreciate you bringing it up in terms of the impact on real people and real families.
Great, thank you. And Dr. Bendat?
Yeah, so ultimately non-compliance with parity and with the essential health mandates is that patients either are undertreated or not treated at all, and ultimately end up far worse than they began, if not dead. And it's very simple.
Well, I thank you for your clarity and bluntness, because I do think that that's really important for people to realize that, this is not sort of a, kind of a bureaucratic, political argument. This is really about saving lives. So thank you. Assuming, we were able to put in, again, a better sort of regulatory structure, someone has to regulate it, okay, and at the Department of Labor, and the agency, that Mr. Norcross's bill, would appropriately designate is the Employment Benefit Security Administration, EBSA, and it's a big job. If we're going to put in a new sort of effective regulatory structure that requires, boots on the ground and resources. Again, the American Psychiatric Association has worked with my office about trying to get EBSA's budget actually increased in this year's fiscal year budget, which again is not sort of our portfolio, but Mr. Chairman, I would like to ask that the Psychiatric Association's statement be added to the record regarding, again, this important piece of the puzzle, if we're able to, again, enact smart legislation.
Without objection, Mr. Courtney.
Thank you. And again, I don't know if any of the witnesses would want to talk about that, because again, obviously having, a cop you can pick up the phone and call when there's a non-compliance issue is kind of a critical piece. And obviously the Psychiatric Association, I think, flagged this for Congress, and I don't know if any of you wanted to sort of join in with any comments.
Well, I would add that there's absolutely no doubt that strengthening EBSA's ability to enforce parity in ERISA, particularly with respect to mental health benefits, is critical. Again, it's a large department, but by no means substantial enough in order to be able to take on 136 million people. You can imagine at least 1/5 of which have mental health and substance use disorders. That's a national statistic. So think about what that means for EBSA's regulation and the importance of being able to effectively address issues that states cannot touch because of preemption. Again, critical.
Thank you. Well, you get the final word, Dr. Bendat. And again, I appreciate the witnesses' really, great testimony on such a critical issue. I yield back, Mr. Chairman.
Thank you, Mr. Courtney. I'll now go to Ms. Stevens.
Well, thank you so much, Mr. Chairman, for this critically important hearing. Particularly, is it something that I hear from constituents and stakeholders in my district on the regular, from the Livonia Chamber of Commerce, President Dan West, who asked me about what we are going to do to meet the moment to improve access to behavioral and mental health care. And our panelist, who has done just a great job today, and I want to recognize you, Dr. Moutier, for your testimony and your expert answering of questions. Although the last 2 years have seen an overall reduction in suicide rates, the number of young people who have reported suicidal ideation has increased dramatically since the pandemic. And I know you have been touching on this throughout today's session, but over the past year, communities in my district have just experienced countless tragedies of young people dying by suicide, oftentimes with no warning indicators and no recognition that they might be depressed or might be in need of help, going out with their friends or family the night before such a tragic incident takes place. So Dr. Moutier, can you just speak a little bit to the importance of
some either early recognition or community conversation that we can take, the accessing of care, and maybe the ways in which we can broach this topic as community leaders more effectively. And if there's anything that we need to know about trends or maybe not fully developed brains that are also contributing to these tragic incidences.
Thank you so much. This is such a huge part of the pandemic experience as well, because young people, as you mentioned, our brains don't finish all the way developing until we're in our mid-20s. So it means the primitive part of our brain, fear, anxiety, stress, fight or flight, is fully developed. But the thinking part, the planning part, the part that allows us to see the long-term future and see through the crisis moment is not fully in place for most people until the mid-20s. And so impulsivity can be a much greater factor for young people when they're in suicidal distress. And that is something that we are gravely worried about. Again, stigma going down is fantastic, but that has to be just the start. And so we have to build capacity for parents, communities, faith leaders, schools, personnel, workplaces to have dialogue about these experiences. Because the truth is, while it always feels out of the blue and like you're blindsided by a suicide attempt or a death, the truth is that person was experiencing something that we as a society have not provided ways for them to express and have their needs met. And that's what we're building. And we are doing that, but much more is needed in that regard.
Right. And just as we say that we have been working really closely with stakeholders on removing the stigma of depression and trauma and needing help or asking for help and providing those spaces, we also want to send the message that we don't want you to kill yourself, and that it is, that we want you to get the help. And so looking at, the role that mental health services play, or just the understanding of, for an underdeveloped brain, what actually happens when you do kill yourself and the results of it. Dr. Smedley, COVID-19 has had devastating consequences for millions of people, but there are, also just some lessons that have been learned from this pandemic that will allow us to improve healthcare moving forward, including the advancement of telemedicine and making mental health services available in communities that might traditionally lack access. Could you just walk us through some of the things that we've learned during the pandemic about the different ways that mental health services can be provided? I know we've been covering that at length today. And also, do you have any other recommendations for Congress so that we can ensure high quality mental health services are available in community, including communities that might be lacking sufficient access to the internet, for example?
Thank you, Congresswoman. I'll try to speak very quickly because I know
Yeah.
it's running short. And I would love to offer a full written response as well, but you are absolutely right that we need to ensure that culturally appropriate community-based services are available. I would point out that suicide rates are particularly escalating among African-American and Native American youth. We need to have services in communities for those young people. And so we will be very happy to provide a fuller written response to your question, given the time.
Thank you. And I yield back, Mr. Chair.
Thank you for yielding back. Very artfully getting that last question in was good work. Excuse me. So that is our last testimony, unless I've missed someone. I'm gonna, before we go to the ranking member for closing comments and then conclude, I just want to thank everybody again. Thank the members. Terrific hearing, an important one that we intend to pursue on this committee, and would love to work with all of you in a bipartisan way. I'm sure we're going to have some differences in terms of the deployment, but what I hear that's so encouraging, and just following up on the last conversation, it's striking to me, having been involved in this field for a long time, personally and professionally, that the lack of stigma, and it's really beyond my expectation when I started in this 35 years ago, that we don't have this more stigma. So the wonderful thing, I thought it would I'm encouraged by that. Having said that, it's very frustrating to see the richness of the research and the ability to get that research deployed to individual Americans. We're losing people that we don't need to lose if we get the infrastructure up and get the performance standards right, so Congress can provide the necessary oversight. So I want to remind my colleagues that pursuant to committee practice, materials for submission for the hearing record must be submitted to the committee clerk within 14 days following the last day of the hearing. So by close of business on April 28th, 2021, preferably in Microsoft Word format. The material submitted must address the subject matter of the hearing, obviously. Only a member of the subcommittee or an invited witness may submit materials for inclusion in the hearing record. Documents are limited to 50 pages each. Documents longer than 50 pages will be incorporated into the record via an internet link that you must provide to the committee clerk within the required timeframe. Please recognize that in the future that link may no longer work. So just we'll work with you as best we can, but we wanted to give you some warning. Pursuant to House rules and regulations, items for the record should be submitted to the clerk electronically by emailing submissions to an edandlabor.hearings@mail.house.gov. Member offices are encouraged to submit materials to the inbox before hearing or during the hearing at the time of the member makes the request. We will furnish that email to anyone who has trouble getting it. Again, I want to thank the witnesses. Really terrific hearing. Thanks for your vocation, your commitment to these issues. It's certainly an exciting time to be in your field with your expertise, and we intend to take advantage of your expertise. And I would include all of those, the witnesses. Mr. Gelfand, I really appreciate your perspective. Members of the subcommittee may have additional questions, and that we ask witnesses to please respond to those questions in writing. The hearing record will be held open for 14 days in order to receive those responses. I remind my colleagues that pursuant to committee practice, witness questions for the hearing record must be submitted to the majority committee staff or the committee clerk within 7 days. The question submitted must address, again, the subject matter of the hearing. I now recognize Mr. Allen for any closing comments that you have. Go ahead, Rick, if you could unmute.
Okay, we'll try again. Thank you, Mr. Chairman, and I want to thank all the witnesses for their testimony today. This has opened my eyes a great deal to the complexity of this issue. I would like to ask unanimous consent to enter in the record statements from the American Benefits Council and the HR Policy Association.
Without objection.
Thank you, Mr. Chairman. And to just highlight a couple of things that I think are important, particularly you're listening to the discussion today that we need to consider, is according to a 2020 Congressional Budget Office estimate, 151 million Americans receive health insurance through employer-provided plans, which is the largest single source of coverage. Yet, Democrats are seeking to eliminate employer-sponsored health care through their socialist Medicare for All plan, which would force millions of Americans into a one-size-fits-all government-run system and cost more than $30 trillion over the next decade. A 2018 survey by America's Health Insurance Plan reveals that 71% of Americans are satisfied with their current employer-provided health coverage. By all metrics, satisfaction with employer health coverage outpaces public support for the Democrats' Medicare for All scheme. Employers around the country continue to make concerted efforts to meet the mental and behavioral health needs of workers through implementation of coordinated care programs, employee wellness programs, use of telehealth services, and additional employee assistance programs. The Democrats will ignore this fact and unjustifiably assume that employers are shortchanging their employees. I encourage members to talk with companies about this and find out exactly what they are doing so we can get to the root of the issue. House Republicans want to empower America's job creators to expand access to quality care and mental health services for workers and their families. While the system can be improved, we also recognize employers are attuned to the needs of their employees, as I know firsthand. For 37 years, I ran a construction business where we provided staff benefits. I knew my employees' needs and what benefits and services were best suited to meet their needs. That is why I believe employers play a critical role in enhancing the system moving forward, which will benefit workers by ensuring that effective mental and behavioral health services are offered. I believe that employers truly know that their employees are the most important factor in the success of their business, and they want to take care of them. Again, I thank the witnesses for participating today, and I yield back.
Thank you, Mr. Allen. Look forward to continuing conversation, discussion with you. We have mutual experiences as former employers, you in the construction industry, and I admire that, and myself in the restaurant business, as I've explained many times in this committee. One of my big concerns about employer-based wages and benefits is not that the employers are bad or inherently bad, but some of them are. So I think the discussion is, and I always, some of my colleagues on the left, sometimes are surprised that I actually admire some of the work by Francis Fukuyama at the Hoover Institute, and particularly his work, Trust, about the most efficient way to deliver services. Having said that, and government isn't always that provider, what we want to do, and what I've heard clearly from everyone's testimony, and I hope we can focus on, is the importance of these services, being able to have metrics so we can measure them both at the clinician level, through the employer relationship and the health provider relationship, but most importantly for Congress and the Department of Labor, for us to be able to clearly evaluate the quality and the access for Americans to get these services. Because my own belief is over the next 30, 50 years, as all this research evolves, we're going to learn a lot, and we're going to save a lot of people's lives and allow them to be able to live great lives, even if they've been challenged either genetically or through their environment. So I'm really excited about this. I really hope, and I appreciate the testimony and the tone, that for me, I want to focus on the deliverables of these important resources as we go through it. And I know you do too, Rick, and I'm looking forward to focusing on that. We'll have our disagreements, and I respect that. But you and I share a perspective. In my case, we both ran low profit margin businesses. The restaurant business is historic, so it was just getting the services that my employees needed, that I wanted them to get. And then the challenge of competing against other employers who weren't doing the things that you and I did and tried to. And in California, we had a big initiative that was bipartisan to get at the underground economy to incentivize employers who needed those incentives. So I agree with you. The hammer is not always the best tool to reach for in the toolbox. So I'd love to work with you to figure out ways to get those, to reward those good employers. And Mr. Gelfand, I'd be happy to have those further discussions, but also to be mindful, human nature being what it is, that not everyone, whether they be employers or employees or providers, always have those best interests. So how we do that, I think, is really important. And it would really be wonderful, I think, for this country to know that this little subcommittee really focused on those things and accepted the fact that we're going to have some disagreements. But the delivery of these services are so important. And we're losing. We've lost 87,000 Americans to overdoses in this country. When you look at diseases of despair and deaths of despair, wonderful but sad book, a recent book on this subject matter, there really is an urgency. We're losing too many people every day. For me, this is personal, as I've mentioned. On April 20th, it will be the 32nd anniversary of when I found out that my father took his life. He had had chronic problems with substance abuse and depression. He was actually the first behavioral health substance abuse counselor. He went back to college, got a master's degree at Rutgers so he could give substance abuse counseling to the New England Patriots players and staff. He was terminated after a couple of years because they got a new coach who said, and the Sports Illustrated editorialized against this, the new coach said, these are professional athletes, they don't have substance abuse problems. So we can look back on that comment and that culture and say that clearly isn't true either for them or for the general public. So as I reflect on my dad's experience and having lost him and the years I've spent dealing with that, but also discovering the things that we could do and the wonderful work you all do, but particularly Ms. Baudier and a bill that we've worked with your group on that we help provide for services that will help with suicides. But there's so much to be gained. And I think back on my dad and think, you know, if we knew then what we know now and got him the services, he wouldn't have done what he did, and he would have lived a full contributing life where he could have helped other people who dealt with this depression and substance abuse. So I'm not depressed by that. I am encouraged by how far we've come, but I do feel the urgency, and we're going to work on this in this committee. And lastly, just an observation, the jurisdiction of this committee and the relationship of employer-employee benefits, of course, came up historically during out of the Depression. And to some degree, it is the jurisdiction of this committee, and we'll focus on that. But be mindful that although this is a key component, there's so many other areas. And I think of a field hearing that then Chairman Fox had in the Bay Area about 5 or 6 years ago when we dealt with the gig economy and how we get benefits to people who don't have traditional employer-employee relationships. So I'll conclude there and just say again, how encouraged I am. And Mr. Allen, I hope you share this at the tone, the tenor of this conversation and all of our witnesses. And I want to thank the staff again and look forward to really delivering for the United States on a bipartisan level to get these services to people out there in the community so there'll be less suffering tomorrow, next month, and years to come by people because we deliver these services to the American people. Thank you so much. We are now adjourned.